So make sure you're good with all of your pregnancy-related emergencies. Okay. Strokes and TIAs and increased ICP and all that good stuff. All right. Cushing's triad. So we talked about Beck's triad earlier, and Beck's triad deals with cardiac tamponade, right? Cushing's triad, another three things. Cushing's triad indicates your increased intracranial pressure. So we got to be really, really careful that we don't get our triads mixed up, okay? Cushing's triad indicates increased intracranial pressure when your patient has some sort of head injury. Okay, it can come from trauma, head injury. It could also be from a stroke, right? Hemorrhagic stroke or meningitis, you know, that could cause it too sometimes. But what we've got is we've got three things, the signs and symptoms. The first thing is going to be hypertension, specifically systolic hypertension, because you have what's called the widening pulse pressures, where your systolic blood pressure is increasing, but your diastolic stays normal, right? So those pulse pressures is widening as your systolic gets higher and higher. Your second thing is going to be a decreased heart rate or bradycardia. And then your third sign of Cushing's triad is your irregular respirations. Okay. So when you see those three, automatically take a look, you know, what's going on with this patient's head. Do we have trauma to the head? Are they experiencing a stroke? Do we have weakness? Do I need to do a stroke scale? That kind of thing, right? Really, really, really pay attention to your vital signs, because your vital signs can tell you a lot. So what are some issues when someone has a altered mental status? Well, the first thing, and I'm just going to go ahead and throw this in here, altered mental status can be caused by so many things, right? So altered mental status and this can just be something that will make you really kind of think about this. We think about another acronym is called AEIOU TIPS. Okay, AEIOU TIPS. This is anything and everything that could possibly be causing altered mental status. I know that I tell you guys, you know, the brain needs two things, oxygen and glucose, and those are two absolute things. So anytime someone has altered mental status, we're looking at their breathing, we're looking at their oxygen status, and we're looking at their glucose. But there's so many other things that can cause altered mental status that it's important that when we're trying to figure it out, you're asking your questions, you're doing your assessments, you're doing all that kind of stuff. So AEIOU TIPS is really good to know. So alcohol, right? Acidosis, if their CO2 levels are too high. Okay, arrhythmias. There's lots of different A's. E stands for electrolyte imbalance, right? You know, if you're sweating too much, not only can we go through heat emergencies, but you can also be altered, right? Endocrine, that's your diabetics. Epilepsy, that's your seizures. I stands for infection. If you have a patient with, an infection or, that's sepsis or it's getting into sepsis, then they can be altered from that. O, overdose, oxygen, opioids. U is uremia. I think you guys get the gist here. There's a lot of things. And when you have a patient with altered mental status, you have to check everything. T, temperature, trauma, right? I, insulin, again, endocrine and insulin, right? P, you could have psych issues or poisonings, right? Overdoses are a little bit different than poisonings. S, there's a lot with S, strokes, seizures, syncope or syncopal episodes. That's when someone faints, right? They could have a space-occupying lesion or like a tumor in their brain, right? They could have a shunt malfunction. So if your patient has a brain shunt, right? There's so many different things that can cause AEIO or that can cause altered mental status. So AEIOU TIPS is kind of something that we take a look at. We just kind of keep that in the back of our brain when we're thinking about mental status. But specifically, strokes and hypoglycemia, these are very similar to one another. They can mimic each other, right? So what is a stroke? Well, a stroke, remember, is the inadequate perfusion of cerebral tissue due to an occlusion or hemorrhage. Whether it's a ischemic stroke because there's a blockage in their cerebral artery, right? And this is not their coronary arteries. Coronary arteries are in the heart. Cerebral arteries are in the brain, right? And then, or it could be from a hemorrhagic stroke where there is an actual hemorrhage going on in the brain. So let's see if I can pull up real quick some brain. Oh, what am I trying to do here? Well, let's see here. That's not what I wanted. I want... I don't know if I'm going to be able to pull up what I'm trying to find here. Ooh, maybe this one. Maybe this one's going to show it. No. Nope. Anyway, I know on a previous... what was I going to... On a previous exam review, I know I pulled up some of these. No, I'm not going to be able to find what I'm looking for. Okay. Oh, maybe this one. So we're looking at, this is what I want to see. You're looking at your cerebral arteries, right? And if there's like, it has this little arrow, there's a clot right here, which means that all of this over here, you see how you don't see anything. You don't see all the little squiggly lines because there's no perfusion. That is completely blocked off. So that's your ischemic stroke from your clot, right? I really wanted to show like before and after. Okay, this one's good. So you kind of like see a before, right? You've got your clot right here, and all of this is white. So there's no no imaging of any kind of perfusion. But after they clear that clot, it's now reperfused. You now actually see the blood flow in that area. So anyway, that's all I really wanted to show you was you know, from our ischemic strokes. Our hemorrhagic strokes is when there's a bleed. Okay, when there's a bleed. Nice bleed right there. Okay, and that obviously will cause altered mental status. Okay, your ischemic versus your hemorrhagic stroke. You're going to see Cushing's triad with those. Okay, you're going to see Cushing's triad. Hypoglycemia is also, you know, can also cause altered mental status because the brain isn't receiving enough glucose to function normally. Okay, and remember the brain needs oxygen and glucose to function. So that altered mental status, when you get there, check their oxygen levels, check their breathing, check their glucose, do a quick, you know, glucose check with that glucometer, and do a fast exam to check for stroke-like symptoms, right? And intracranial pressure, remember, increased intracranial pressure can result from bleeding or swelling in the brain. That forces the brain out of its normal position. It's going to compress the brain to where it may herniate out of that foramen magnum, right? And that hole at the bottom of your skull where your spinal cord exits. So if there's so much swelling and so much, you know, going on in there, bleeding or swelling within the brain, your brain can absolutely be displaced and kind of pushed through that hole. And that's where you get that decorticate and decerebrate posturing that we see in our Glasgow Coma Scale. Okay. All right. The patho with meningitis, heat stroke. Okay, so these are just again some comparisons. So we've kind of talked about meningitis already with the kiddos, but meningitis, remember, can come from viral causes, bacterial, fungal, or parasites. This is an inflammation of the tissues that cover the spinal cord and the brain, those meninges, right? If it is left untreated, then it can cause permanent brain damage and death. It can, okay? So if your patient is experiencing, that stiff neck, because if they have inflammation of those meninges, it's really hard to bend their neck forwards or backwards. If they have, a fever with that altered mental status and we just can't figure it out, it could possibly be meningitis. Some key words. Pediatrics, there are some pediatrics that are at a greater risk for meningitis. Males are, newborn infants are definitely, because they can't, their immune system really hasn't kicked into gear yet, right? Children with compromised immune systems, maybe they have a history of a brain, spinal cord, or back surgery that can cause meningitis. Maybe they've had head trauma, or they have shunts or pins or any other foreign objects or foreign bodies within their spinal cord or their brain. Those individuals are more prone to meningitis. Now, heat stroke, remember a heat emergency is where we have too much heat within our bodies, right? The body, the loss of heat is not enough. Okay, so the loss of heat is not enough, and so we have that heat build up in our bodies. You have your heat cramps, your heat exhaustion, and your heat stroke. Your heat stroke is the worst one, and because at that point our body has lost its ability to thermoregulate. We cannot cool ourselves anymore. So a heat stroke, you're going to have hot, dry, and flushed red skin. Okay, it's dry because we can no longer sweat. You'll have confusion, altered mental status, seizures. Patient can be completely unresponsive. Now, the difference between adults and kids with heat stroke is, adults, for the most part, we know when it's too hot and we come inside. We know that we have to drink our fluids and stuff like that. But kids, there's a lack of judgment of when to come in and when to hydrate during hot weather. Sometimes when they're outside playing and having a good time and all that, they don't think, oh yeah, I need to keep drinking my water to make sure I'm still okay. And I'm getting too hot, I need to come inside. It's just one of those things. They're young and they lack that judgment, but they also are at a greater risk for heat emergencies. Then they're at a greater risk than adults because their fluid reserves are smaller than those in adults. Okay. They also have a poor thermoregulation at those young ages. Children feel heat and humidity faster and more severely than adults, and they have a harder time cooling down. And then you add on top of that lack of judgment where they're like, no, I want to keep playing, and I'm not going to drink any water. And now you've got a problem, right? Intracranial pressure, we've talked about what it is, but as far as adults versus pediatrics, I want you to think about that kiddo that has their heads are proportionately larger than their bodies, right? Or not larger than their bodies, but they're just proportionately larger the younger that they are. So they're more susceptible to head injuries because of the size of their head. And children tend to fall head first. Okay? And remember those fontanelles, if it's a bulging fontanelle, then it can hide the signs of that increased intracranial pressure. It can hide those signs that we would normally see. So back to a stroke versus TIA. Remember that lookalikes PDF that we were talking about earlier? If you go to that lookalikes PDF, there's your acute MI versus your angina. There's your CVA versus your TIA. Okay. So the treatment is the same. But your stroke, this is that cerebral perfusion, right? Interruption in cerebral perfusion that's occurring. This is not temporary. The temporary one is the TIA, okay? That's your temporary one. But your CVA is that inadequate cerebral perfusion. Remember, it can be from ischemic or clots or hemorrhage or bleeding in the brain. And your TIA is your temporary blockage that produces the symptoms of a stroke. But your TIA will usually resolve, it self-resolves, so there's no intervention. It will usually resolve within 24 hours, okay? Now, here's the thing about strokes and TIAs. You never know which one they're having, right? And because we don't know which one they're having, we always err on the side of caution and think, okay, this patient is positive on the stroke scale. Pretty sure, we just need to take them to a stroke facility. It doesn't matter if they've had TIAs in the past, and you think this might be another TIA. You don't know. It might be a stroke. It might actually be the big stroke. And there's nothing that happens beforehand that's going to tell us whether or not it's a TIA or a stroke. It's always on the back end when the TIA self-resolves on its own. But we don't have the time to wait around to see if that happens. So you always err on the side of caution and, activate your stroke teams and get them to those stroke facilities. Okay. What's the most important question to ask a patient with those stroke-like symptoms? The most important question is, when was their last known normal? Because last known normal is going to tell me approximate time that this stroke may have started, and that will help with the treatment options that they receive at the hospital. The FAST exam, FAST, that is your facial droop, arm drift, slurred speech, and T stands for time. Okay, this is what we do for our patients. This is our stroke assessment that we have to do for our patients that we think is experiencing a stroke. And remember, if you have a patient that has altered mental status, go ahead and do a stroke assessment, because you just never know, right? You just never know. So, okay, here's your FAST assessment, right? Super simple. Do they have facial droop, right? Have them smile. You should see symmetrical smiling. If they have droop on one side, then they're positive. You don't even have to have the other ones, right? They're positive. Arm weakness, you can have them put their arms out in front of them, right? I always say, put your arms out in front of you like you're walking like a zombie. Close your eyes, hold your arms out. If they have weakness, if one of them drops off to the side, then that's positive, right? If you want to do grip strength, you can do that too. Squeeze my hands as hard as you can. And if you have one that's less than the other, then you have unequal grip strength. Speech, it's not just slurred speech, but it's difficulty speaking, right? So remember earlier when we were talking about GCS and we were talking about those inappropriate words, you can have someone that's experiencing a stroke and they can form their words just fine, but there's a disconnect between their brain and their mouth. And so the words that are actually coming out are not appropriate. So if they're having a hard time talking to you, whether it's slurring their speech or they're not able to say the words, the appropriate words, then that's a problem. And then T again, T is always time. If we were, if you were out in a public place and all that kind of stuff, then, that's why this one is said time to call 911. But we want to know, when was this person last seen normal? That's what we want to know from the T. So the FAST exam is super, super important. Really easy to do. Just do a quick FAST exam. Drugs, medications. Okay, we already did this one, stimulants and depressants, earlier on, but just remember your stimulants, this is your central nervous system stimulants. So they're going to key everything up, right? You're going to have increased heart rate. You're going to have tachypnea, increased body temperature, right? That's a big one. So they're not going to be able to cool themselves off. So they're going to be diaphoretic and sweating. Blood pressure is going to be up. They're going to be paranoid and anxiety, and everything's going to be up, okay? Your central nervous system depressants, you're going to have respiratory depression. You're going to have airway issues because they're going to be so relaxed. They could have seizures, unresponsiveness, things like that. Specific stimulant drugs, you've got your caffeine, your ecstasy, right? Your cocaine, methamphetamines, PCP. Depressants, you will have marijuana, K2, date rape drugs, ketamine, okay? Your opioids or your opioids are central nervous system depressants. So any kind of opioid also would fall underneath a depressant. Okay. Now, what about pharmacology and what you can do for your patients, right? This is the pharmacology that we can actually do. So in your book, if you look at, let me find what table that is. In pharmacology, which is your chapter 12, table 12-4, this goes over all of your pharmacology, right? But also, if you remember, if you look at your weekly schedule and you look at that medications PDF, this goes over all your stuff also, right? Okay, all the things that we need to know. So when you're looking at your final exam review and you're thinking about what you're going to do, how can you treat your patient? This is what we're talking about with your actual medications, okay? We know our skills, we've got our bleeding control, we've got our airway management, we've got all that kind of stuff, but this is, can I actually give a medication to help with what's going on? So my expectation is you guys know everything about all the drugs you can give. Mechanism of action, how does it work? When is it indicated? When is it not indicated? So when is it indicated? When do I do it? When can I not do it? Because there's something that is contraindicating its usage. The doses for both adult and pediatric, and then the side effects. What are you going to see happen after you give it? So albuterol. We've got albuterol is a bronchodilator. That's the mechanism. That's what happens in the body. It's a bronchodilator. So the indication of albuterol is when your patient is wheezing. Okay. Contraindications would be if your patient is tachycardia or is experiencing tachycardia, because that is a side effect that happens with albuterol. But you want most of the time, you're not going to see life-threatening tachycardia from albuterol unless we've given a lot of different or a lot of treatments back to back to back. Okay. Let me see here. Let me pull this up. Okay. So it's a bronchodilator. We use it when our patients are wheezing. Contraindications would be, tachycardia. And the dose, 2.5 milligrams in 3 milliliters of normal saline. That's normally how it comes. So 2.5 milligrams, that is one treatment. We put it in the nebulizer chamber with the nebulizer mask, place that mask on our patient's face, and we hook that oxygen up to 6 to 8 liters per minute. It's the same dose for an adult and a pediatric. Activated charcoal. Remember, we use activated charcoal for ingested toxins. Okay, ingested toxins. It will bind with that toxin and minimize its absorption into the system. Okay, so the indication is going to be for ingested toxins. Side effects, it's going to cause some nausea. It might cause some vomiting. It's going to cause their stool to be black afterwards, right? Because it is activated. It's an oral treatment. Okay. And of course, albuterol is an inhaled route. Okay. So activated charcoal, the dose is going to be 1 to 2 grams per kilogram of body weight. Aspirin. Aspirin, what does it do? Aspirin is an antiplatelet, right? That's the reason why we give it. It's an antiplatelet. And so if your patient has an occlusion or a clot in their coronary arteries, then I give that aspirin to make sure that that clot doesn't get any bigger. That's why I give it. So the indication is going to be cardiac-related chest pain. Contraindications would be, of course, if my patient was allergic to it, right? Because we always check A, you do have any allergies to any medications. So allergies to aspirin, or if your patient has an active GI bleed, active bleeding ulcers, or some kind of active internal bleeding, that I don't want to give aspirin because it'll just make it worse. Okay. The dose of aspirin is 324 milligrams only for adults. I don't give it, I don't give aspirin to kids, right? So 324 milligrams for adults. And this is an oral medication that they will chew up and swallow without water. Okay, so it's a dry chew. They chew it up. Epinephrine. Remember, epinephrine is it stimulates that sympathetic nervous system, okay? It's actually the hormone that gets released when our bodies stimulate its own sympathetic nervous system. But if I'm going to give epinephrine from an outside as an outside source, then it's going to mimic all that same stuff, right? So what does it do? It causes bronchodilation. It causes vasoconstriction. It's going to increase the heart rate. It's going to do all that stuff, right? It's indicated when your patient is having an anaphylactic reaction. Okay, so when your patient is having an anaphylactic reaction, then that means I got to give my epi. Okay, contraindications: if your patient is experiencing cardiac-related chest pain, I don't want to give it. If they're hypertensive, then I don't want to give it. Remember, if your patient has anaphylaxis, then they're going to be hypotensive because that's a distributive shock problem. Okay. This is an intramuscular injection, and the route is intramuscular. The dose for my adults is 0.3 milligrams, and the dose for my pediatrics is 0.15 milligrams. Okay, side effects: it's going to cause all those things from the sympathetic nervous system that we talked about. Okay, but I give it because I want to bronchodilate for help with breathing, and I want to vasoconstrict to help with that distributive shock that's going on. Oral glucose. Okay, oral glucose. Its mechanism of action is it will increase the glucose available in the blood. Okay, that's what it's going to do. Your body will absorb it and rather quickly, and it will increase the blood glucose levels. So the indication, or when I use it, is when we are hypoglycemic, right? That's when I use it. The contraindications, of course, would be if I'm hyperglycemic, right? Don't want to give it if they don't need it. But because oral glucose, it's given orally, then that means this patient has to be awake. They have to be able to maintain their own airway. Okay, so it's not a confusion thing. I think a lot of people think, oh, the patient's confused, I can't give it. Confusion is a sign of hypoglycemia. But if your patient has a decreased level of consciousness to where they cannot control their airway, that's the contraindication. That's when I can't give it to them, right? So if they have a decreased LOC, decreased level of consciousness, then I can't give it to them, because it's not safe, right? The dose is going to be 15 grams, which is 1 tube. That's the dose for the adults and pediatric patients. What's it going to do? Like we said, it raises the blood glucose levels. Okay, some side effects. It could cause a little bit of upset stomach, but we need to get those glucose levels up, right? Nitro. Nitro, I'm going to give this to my cardiac-related chest pain. Okay, what does nitro do? It is a vasodilator. So I want it to vasodilate those coronary arteries. So if there is an occlusion, I can increase the blood flow through those coronary arteries to those distal tissues and deliver oxygen, right? So this is for cardiac-related chest pain. Contraindications of your nitro. Because it's a vasodilator, then I need to be careful of their blood pressure, right? So contraindications would be hypotension. If your patient has a systolic blood pressure of less than 90, then I cannot give nitro. Okay. And if you give multiple nitroglycerin treatments, then you have to check your blood pressures in between every treatment, right? To make sure that their blood pressure is good to go and can manage and handle the nitro. Another contraindication would be if your patient had taken any erectile dysfunction meds in the last 24 hours. That's an absolute contraindication because their vasculature is already vasodilated. Side effects: it will cause your patient to have a headache, and it will also cause, again, their blood pressure to drop a little bit, which is why we have to continuously watch it. The dose, 0.4 milligrams for your adult. This is a sublingual route of administration. Okay, sublingual route of administration. And if it's a spray, it goes under the tongue. And if it's a tablet, Again, it goes under the tongue where it will dissolve, right? We don't want our patient to chew it up or swallow it whole or anything like that. It needs to be dissolved and absorbed. We do not give nitro to our pediatric patients. And then Narcan or naloxone, what does this do? Narcan will reverse the effects of an opioid overdose. That's really what it does. So the indication is an opioid overdose, but specifically when your patient is experiencing respiratory depression. Okay, if your patient has ingested opioids and they do not have respiratory depression, then we don't give it, right? So your patient has to have respiratory depression. Contraindications for Narcan, there's really none in the emergent setting. You just got to give it, right? Side effects to Narcan is going to be nausea and vomiting, rather violent nausea and vomiting, because when they come out of their overdose, they're going to be throwing up. So we need to get that suction ready, right? And then the dose is 2 milligrams. And the route of administration is intranasal, and I do 1 milligram per nostril for a total of 2 milligrams. Okay. All right. So again, make sure you know everything about your pharmacology. Shock. We've talked about shock so much that I really, really, really hope you guys are good with this. Okay. But we're going to talk about it again. I'm not going to go crazy into detail because we've talked about it so much, but let's talk. Okay, so shock. First, I want you to think about your cardiac output formula, right? That cardiac output formula, this is your most important thing. Well, that has MAP. That's not what I wanted. MAP is good to know too, but I want you guys to look at cardiac output. We'll just do this one. Remember, cardiac output is the amount of blood that's pumped out of the heart. And heart rate is how many times your heart beats per minute. Stroke volume is the volume of blood pumped per heartbeat, right? So cardiac output equals heart rate times stroke volume. When we're thinking about a patient that's experiencing shock, it affects their stroke volume, okay? So if we're going to go back over here to our review, I actually want to look at the differences of compensated shock versus decompensated shock first. I want to look at those first, okay? So when you have something that's affecting your stroke volume, and we'll talk about all those different shocks in a minute, then your stroke volume drops. And in order to maintain your cardiac output, your heart rate will increase, right? And this is in the first stages or the early stages of shock. Your heart rate will increase in order to maintain your cardiac output, to maintain your perfusion. And so compensated shock, your vitals, you will see tachycardia and normal blood pressure. As whatever is going on with shock, as it continues, if it doesn't get managed or stopped or anything like that, then your stroke volume will continue to drop and continue to decrease. So the problem persists, right? And at that point, the cardiac output, as much as this heart is trying to work, and it's going, it's tachycardic, as much as that's trying to help, eventually your cardiac output is going to drop. So that's what decompensated shock looks like. And that's when in our later phases of shock, when the problem has persisted, stroke volumes dropped, we now have tachycardia and low blood pressure, or that developing hypotension. So those are the two different phases of shock. Super important to know that, because that's how we recognize it, right? Okay. Plus, your patient is most likely going to be experiencing cool and clammy skin, right? So cool and clammy. All of your shocks, all of them, except for neurogenic, but all of your shocks will be cool and clammy. They're going to have those vital sign changes, tachycardia, developing hypotension if we're in decompensated shock. Okay. And there's going to be something that's causing it, right? So the different types, let's go back up to this one, the different types. You have hypovolemic shock, distributive shock, obstructive shock, and cardiogenic shock. And remember, in order to have shock, you have to have a problem either with, like you have to have either inadequate blood volume, inadequate heart function, or inadequate vessel tone. So if I have hypovolemic shock, hypovolemic, that's low volume, that's a volume problem. That's inadequate volume, blood volume, okay? So we either have bleeding, whether it's external or internal bleeding, or your patient could have volume issues from dehydration. Maybe they have nausea, vomiting, and diarrhea, and they're not replenishing their fluids. Maybe they've been working a lot outside, and they're sweating off a lot of their fluids, and they're not replenishing it, or not replenishing it at the rate that they need to, so they get dehydrated and volume depleted. That's your hypovolemia. Every shock will go through the phases, right? So if your patient is not feeling very well, maybe they're a little bit pale, a little bit cool, and they're tachycardic, they're probably in shock, man. Take a look at what's going on, you know? Okay. If they're tachycardic and hypotensive, then absolutely, right? So if it's a bleeding issue and we can control that bleeding, remember your bleeding control, right? We've got our direct pressure is the biggest one, is the first thing that we do, direct pressure. If it's on an extremity, then I do direct pressure, and then I go straight to a tourniquet. If it's in one of those junctional areas, then I'm going to do direct pressure, and if that doesn't work, then I will pack the wound. And if it's in my torso, like my abdominal cavity, then I'm going to do some pressure, but I can't pack that. I can't put a tourniquet on that. So I'm just going to put pressure, rapid, and rapid transport. Okay. But deal with the problem. Can you manage the cause of the shock to keep them from deteriorating any further, right? Okay. For distributive shock, that is an inadequate vessel tone. Okay, so that's a vessel tone problem. Distributive shock means that we have systemic vasodilation, right? Body-wide vasodilation. That's what's going on. Okay. You have enough blood, you have, and your heart's working just right, but your blood volume is, or not the volume, the vessels, you have a problem, right? So the easiest way for me to explain this is, let's say that you go outside, and I know I've used this analogy before, but you go outside and you're going to water your plants, right? So you go over to the water hose, you turn it on, and you have a pretty good stream of water coming out of your water hose. Now, let's say that just by magic, your water hose goes from a diameter of about 1 inch to now 4 inches. You haven't changed the rate at which the water is coming out. You haven't changed anything. You've just changed the size of the pipe, right? The water is still flowing, but it's just not flowing that great. It's not moving very well because the pipe is too big, right? And in distributive shock, our vessels are dilated so much that the blood volume, although I have enough in my body, the blood is not moving in the way that it should, right? So systemic vasodilation causes distributive shock, and you've got anaphylaxis that comes from that. So make sure you review your anaphylaxis, right? Anaphylaxis, remember, is going to be your patient with that uncontrolled histamine release from an allergic reaction. We've got shortness of breath, got airway swelling, vasodilation, bronchoconstriction, urticaria, hives. All that stuff is most likely going to be present, right? But anaphylaxis is going to be at least 2 body systems, with respiratory being one of them. We can fix that with epi, okay? Sepsis is another form of distributive shock, right? Sepsis, remember, is from an infection. So you have to have a source of infection. That can be pneumonia. It can be a UTI, a urinary tract infection. It could be anything, right? Any kind of infection that causes distributive shock, okay? Because the bacteria, this is what happens. The bacteria from the infection is going to release some toxins, and the toxins is what acts upon the smooth muscle in your blood vessels, and it makes them relax. And that's what causes that vasodilation. So you can have distributive shock or septic shock. That patient needs, we recognize it, we give them high flow O2, right? Recognize, see what the infection is, get them to the hospital where they can get antibiotics. And then the third one that's within our distributive shock category, that is our neurogenic shock. And neurogenic shock is a little bit different from all the other ones because remember, all the other ones, their skin is going to be cool and clammy. Neurogenic is warm and dry. Okay, they're warm and dry because it's not a systemic vasodilation. Neurogenic is from a spinal cord injury, and when you have that spinal cord injury, anything inferior to that spinal cord injury, the nerves are not communicating anymore, and so without that nerve communication, those blood vessels just relax, and you're not getting that nervous system response. So they're not going to be cool and clammy. They're going to be warm and dry because they cannot sweat. Okay, so that's the difference. Your third category is obstructive shock. Obstructive shock kind of falls underneath our inadequate heart function. It's not that the heart is damaged. It's just that the heart's not able to function very well because something's keeping it from doing its job, right? So something's keeping it from doing its job. Obstructive shock, you've got your tension pneumothorax, cardiac tamponade, and pulmonary embolism. Remember your tension pneumothorax, that's where we have that air accumulating in the pleural space around your lung. It's going to collapse your lung. You'll have diminished or absent breath sounds on one side. And as that air continues to accumulate, it's going to compress. It's going to press on the mediastinum where your heart is and push it to the other side and compress that heart. And when the heart is compressed, it's not able to flex and fill with blood like it should. So your stroke volume decreases and you have obstructive shock. Okay. Cardiac tamponade, we've already kind of talked about cardiac tamponade earlier, but again, it's that fluid around the in that pericardial sac around your heart. And when that fluid is there, it's compressing the heart. It's keeping it from being able to fill appropriately, and it's decreasing your stroke volume. All of those, again, will go through compensated shock versus, and then into decompensated if it's not fixed. We cannot fix a tension pneumo. As an EMT, you cannot fix it. You can call ALS and they can come out and they can fix it, but we still need to get them transported to a trauma center. You cannot fix cardiac tamponade. This is transport to a trauma center. Pulmonary embolism, we've already kind of talked about the patho of that pulmonary embolism. It's that clot in the pulmonary circulation. And if you have, think of your right ventricle. Your right ventricle is pumping the blood volume into the pulmonary circulation where it's going to get oxygenated, right? And if I have a clot somewhere in there, then that means the amount of blood coming back to the left side of my heart to be pumped out to my body is less than what went into it, okay? So my stroke volume is decreased. With that pulmonary embolism, we talked about those signs and symptoms, that sudden onset of shortness of breath, sharp chest pain, clear lung sounds, right? Because there's a clot that lodged itself in there. All of those are obstructive shock. We can't treat pulmonary embolism, or we can't fix pulmonary embolism. We have to recognize it and rapid transport to the hospital. All of those need rapid transport. And then your last one that we talk about is your cardiogenic shock. That is inadequate heart function. That's a true heart issue because the heart muscle itself is damaged in some way or is affected in some way, and it's not pumping appropriately because of the muscle itself. Your acute MI, the heart attack, is the most common cause of cardiogenic shock, okay? Because the heart muscle isn't getting its oxygen from the coronary arteries, and so it's not pumping appropriately. And so therefore your heart's not pumping, as well as it has. Myocarditis can do it as well. If there's an infection in the heart, in and around the heart, pericarditis, okay? If there's cardiac contusions, okay, if there's blunt trauma and there's bruising to the heart muscle and part of it isn't working appropriately, but that is going to be your cardiogenic shock. All of those go through, like we said before, your different phases of your compensated versus your decompensated shock. So watch your vitals. It will show you, it'll give you a really good idea about what's going on. Okay, so make sure you're good with shock. Distributive. Okay, distributive was anaphylaxis, sepsis, and neurogenic. The biggest question, the reason why we want to talk about this one is because neurogenic is so different from the others, right? And just making sure that you understand the difference between neurogenic and all the other kinds of shock that are out there. Okay, shock is cool and clammy. Skin is going to be cool and clammy. Neurogenic, they're going to be warm and dry. Okay. All right, we've got a couple trauma things we want to go over here. Specifically, I know this one's, looks specifically at the eye. So let's look at the eye real quick. Okay, we're getting there. We're getting there. Just got a couple more things. We're getting there. Okay. A little bit of anatomy of the eye. The eye, remember, is located within the bony structure of the skull. It's called the orbit, right? The majority of the eye, over 80% of the eye, is actually protected inside or within that orbit. So when you look at someone's eye, you only see about 15% of the actual round eyeball itself. Everything else is inside the skull, inside that orbit. Okay. The aqueous humor is that clear fluid that's in front of the lens. It can leak out when there's penetrating injuries. A couple other things about the anatomy. The white of the eye is called the sclera. The iris is the color that we see, whether we have blue eyes or green eyes or brown eyes or hazel, right? The iris, that color, that's actually a muscle, right? That's a circular muscle that adjusts to allow the light to come in. It adjusts on how much light is let in. And the pupil is the opening in the middle of the iris. It's the opening in the center of the iris that is actually where the light is actually coming in. And that light is reflected, brought back to the back of the eye. Okay. If there is any kind of injury to the eye where part of the eye is exposed or there's problems with that, then we always want to cover it with moist dressings because we don't want it to dry out. Okay. If we need to irrigate because maybe there's small foreign objects in the eye, then you want to flush the eye with normal saline or sterile water. That's fine to irrigate. We always start from the nose side and go from medial on the nose side to the outer corner of the eye. So medial to lateral, you always want to flush towards the outside, but flush it with, good sterile water or normal saline. Think about when you in your chemistry labs and stuff like that, right? Whether you, saw it in high school or you see it in your college classes right now, but they always have like that first aid station and they have the eye fountain. That's really what it is. If you ever get anything in your eyes, whether it's a liquid substance that shouldn't be in there, we need to flush their eyes. If there's any foreign bodies that get in the eye, especially if they're small, then we flush the eyes, okay? But if there are larger objects that get stuck in the eye, maybe they're impaled in the eye, then we don't take them out, right? We'll talk about impaled objects in just a minute, but we never take them out, right? If it's a larger impaled object, that absolutely needs to be removed by a physician. You want to stabilize that object, bandage both the injured and uninjured eye, right? Because remember, they had that consensual movement. So if one moves, the other moves. So we don't want any of their eyes to be moving. So bandage both of them and be careful about putting any kind of excess pressure on that eye. Okay. When you're doing splinting, backboard, KED, or any kind of splinting, because a backboard is considered a full body splint, what do we check before and after? You've got to do pulse, motor, and sensation, right? Got to do pulse, motor, and sensation. And I'm sorry, let me go back to the eyes real quick because I have another note on here. If there's any chemicals, which we kind of talked about this already, but if there's chemicals or chemical burns in the eye, remember we flush it, immediately flush. If there's thermal burns, so if there's heat or thermal burns, cover both eyes with those moist, sterile dressings. Just a little bit more about the eye. The eye is kind of specific because we want to, make sure that their vision is, managed appropriately. So splinting, pulse motor sensation before and after. You guys should know this. You guys are doing it in all your skills. Make sure that y'all are good and you don't forget to check the pulse motor sensation before and after. If they do not have good pulses before, you have one opportunity to adjust to see if you can reestablish perfusion. Okay. If they have good pulses and all that stuff, if they have that, And even if the arm or the leg is in like a really weird position, then leave it as it is, because if you do move it and you move it back to its anatomical position, you could lose pulses on accident just by trying to kind of get the leg or the arm back to its normal position. So that's why we always check before and after. So if they have good pulses and sensation and stuff before, then leave it and you splint it as it is. But if they don't, you have one opportunity to adjust to try to reestablish those pulses, okay? And if you can't, then just splint and rapid transport, right? Probably splint on the way, right? But rapid transport, okay? This is helmet removal. This one is about helmets. When do we remove helmets? When do we not? And then how? So if your patient has a helmet in place, then I have to remove it if I cannot assess or manage the airway, okay? That's pretty straightforward. If I cannot assess or manage the airway, then I have to remove it. I also have to remove a helmet if I cannot place my patient in proper C-spine immobilization with that helmet still in place, then it needs to come off. Okay. Let me make sure there's nothing else. Okay. Yeah. So those are the two big ones. If it's a full face helmet, full face motorcycle helmet, if it's full face, then that means I can't assess the airway. So it has to come off, right? If it's a football helmet or another kind of sports, maybe like a hockey, headgear or something, then, those you could potentially have just the front removed by your physician staff. But if you have this full face helmet, it needs to come off. Okay. If you have come on. I'm looking for, all right, this kind of helmet right here, I would probably be okay with keeping it on, unless it was inhibiting me putting them in C-spine, because I can get their full face. I can assess their airway. Those, oh my gosh, why can't I find one? Sorry. There we go. These guys, right? With the front protective, that stuff can be removed by the staff there, right? I mean, this guy's doing it right here. He's got all the tools to remove all of that. So if you're able to quickly remove that and get to the airway and manage the airway like you need to, then you can do that and keep the helmet in place. But if you can't, then we just got to get rid of the whole thing, right? And so when you remove said helmet, I want you guys, this is two person job, okay? You got one person that's basically holding C-spine. It's going to be this guy, actually, this guy from the front. He's holding C-spine from the front as best as possible, while this other guy is at the head, and he's going to grasp both sides, both lateral parts of the helmet, and kind of pull out and then off, while this other person is holding C-spine from the front. Okay, that's how we do it. It's definitely a two-person thing. Okay. What life threats can occur due to penetrating injuries to the chest? What is their treatment? So penetrating injuries to the chest. Okay, so that means we have what's called an open chest injury. Okay, or a sucking chest wound. That's another thing that you might hear. Okay, but if there's a hole in their chest, and remember this could be anterior or posterior, then we've got to deal with this, right? We've got to deal with this. So the first thing that we do is we put our gloved hand over that hole, because I need to make sure that there's no air that's coming into it. Okay. Then I place an occlusive dressing. You can use a chest seal that has a little valve on it, a little one-way valve. You can use your petroleum gauze. That's a great occlusive dressing if you don't have one of those commercial chest seals, or you can make your own. And remember, those, occlusive dressings, you can get it from, you can use any kind of sterile plastic on your ambulance. and tape it on the wound, but as long as it's only on 3 of the 4 sides, right? So I have this little channel available. So it's going to keep air from going in, but it will allow air to escape if there's accumulation inside, okay? So you see this hole, and it's got a hole down here into the lung. So I'm, having that air accumulate inside that pleural space, and I don't want a tension pneumothorax to occur. So that's why I want the air to be able to escape if it builds up. That's what I want to do. Okay. Let's see here. You got these seals, right? So here's a seal. It just goes on here. Okay. There's a tab to vent and reseal. So they just kind of lift it up with that tab, and it helps to vent it. So that looks like, let's see if I can just find a couple other chest seals. So this, they would take that tab and they would vent it themselves. Okay, this has a little valve in the middle of it. So the valve would allow the air to come out. Okay, so there's lots of different types of chest seals out there, as long as it keeps the air from coming in, but allows the air to vent. That's the most important piece of this. And if you don't have one, if you don't have an actual occlusive dressing, then you can make your own. Okay. The life threats that occur, we can have, it's that pneumothorax, right? It's that pneumothorax. And we don't want it to develop into a tension pneumothorax where you have that obstructive shock, that's starting to occur. Okay. Other penetrating injuries or other things that can be caused by penetrating injuries is your cardiac tamponade, right? We talked about that already, your cardiac tamponade. And you'll see Beck's triad with the JVD, the narrowing pulse pressures. Obviously, they'll have some kind of trauma, the muffled heart tones, and that causes obstructive shock, right? How do we treat it? I can't fix that, but I would do general shock treatment, which is high flow O2, keep my patient warm, rapid transport to the hospital. When we're splinting our joints, okay, so when we're splinting our joints, you want to focus on securing the long bone above and below that joint, right? So for example, I know this says rheumatoid arthritis, that's fine. But let's say that the joint is the wrist, okay? When you're splinting this wrist, you want to secure the long bone above and below it to make sure that this joint's normal movement is restricted, okay? Always check pulse motor sensation before and after. This is actually pretty cool, right? It's a finger, but that knuckle right there, that's a joint. So they have secured the long bones, even though they're not very long, but they've secured above and below that joint to make sure that that joint doesn't have movement, right? Further movement. Okay, it's all fingers and stuff like that. There we go. That's awesome right there. That's what we want. Y'all have seen these orange things, right? So we got a knee. Okay, they've got a knee. So they're going to secure the long bone below and above that knee. Okay, again, check pulse motor sensation before and after. It doesn't have to look pretty, just as long as it works, right? For that long bone injury, it's the same general concept, but if you have a long bone injury, then I'm going to be securing the joints above and below, right? Because I don't want those pieces of bone to be shifting and moving. So let's say that this guy, it looks like they've got knee and okay. So let's say that we have like a tibial fracture or something like that, right? And if you've got two pieces of the bone that's moving, and the top piece of the bone is attached to your knee, and the bottom piece of the bone is attached, towards your ankle, then that's why I want to secure the joints above and below to make sure that those bone fragments don't shift. Okay. And we check pulse motor sensation before and after. Traumatic asphyxiation. All right. Traumatic Traumatic asphyxiation. I don't know why I always have trouble with that. Remember, that is the rapid and sudden compression on the chest that causes the blood to basically stop moving, right? So that sudden and severe compression of the chest, it causes the rapid increase in the intrathoracic pressure. So the blood stops moving and it actually backflows out of the right ventricle into the upper body. The signs and symptoms that you would see are distended neck veins, bulging bloodshot eyes, swollen tongue, and cyanosis from the nipple line up. Causes would be any kind of, again, any compression. If your patient is pinned between two objects, maybe a vehicle and maybe two vehicles, or machinery, or if someone gets, it's terrible, but if someone is, working construction or something like that, and they get buried in a, and they've got that compression of the dirt or the gravel or something around their chest. Even if their upper body is up and out, they've got that that compression on their chest. They can't breathe, and the blood flow isn't moving forward. So traumatic asphyxiation, got issues with that. Significant bone fractures. Okay, so remember, your musculoskeletal is not just splinting and all that kind of stuff, but you've got, all your red blood cells are basically made in your bones, right? So if you have musculoskeletal trauma, fractures and things like that, then you're going to have some kind of bleeding, right? Bleeding and disruption of the blood supply, right? So some of your big fractures, some of your critical fractures are going to be your femur and your pelvis. Okay, your femur you can lose up to 1 liter of blood per femur fracture, and your pelvis can have several liters of blood that drain into that pelvic space. Any large bone, right? If you're looking at your upper extremities, we're looking at the humerus. That's the larger bone of my upper extremities. Any of those that will cause more blood loss. Okay, so let's talk about drowning real quick. So we've got two different kinds of drowning. You have your drowning and your near drowning. Okay. Pull this out. Put this over here. Okay. So you're drowning. When obviously there's a submersion incident, okay, and the death results from suffocation within 24 hours of the submersion. That's going to be a drowning. A near drowning is when there is no immediate death, or death does not occur within the 24 hours of the submersion incident. Okay, wet drowning versus dry drowning doesn't necessarily change the way that we're going to provide our care, but a wet drowning is when they actually aspirate that water into their lungs, and the dry drowning occurs when there's like a laryngospasm happens that closes off their airways, and so water does not get into their lungs. But we're still going to be treating this patient the same, whether it's wet or dry. You're going to be, spinal mobilization, depending upon if there was trauma involved. Most likely there is. So spinal mobilization, suctioning the airway, ventilating your patient, possibly doing compressions if you need to do that, right? Watching for hypothermia that occurred, depending upon the ambient temperatures of the water and just the temperature outside. You're watching for all of that stuff. If you have salt water versus fresh water, it kind of changes it a little bit. Salt water is what we would call a hypertonic solution, okay? Because there's more sodium in it, so it's hyper, right? There's more. Salt water will cause more severe or additional pulmonary edema because it actually draws fluid into the lungs from the blood. Okay, so if you get salt water into your lungs, then it's going to draw fluid into the lungs to try to balance that concentration of salt and water. Okay, so your circulation becomes sluggish and you have increased pulmonary edema now from the salts. Fresh water is considered hypotonic, and you're going to have fluid that moves into the bloodstream. Okay, so if you're in the fresh water, you're going to have fluid that actually moves into the bloodstream, and it will increase the blood volume that leads to destruction of our red blood cells, and of course the inefficiency to transport oxygen at that point, because red blood cells is what takes our oxygen. Okay, it can any kind of water in the lungs will damage the amount of pulmonary surfactant, and surfactant is basically that lubrication in our lungs that allows us to inhale and exhale and breathe easily. It kind of decreases the amount of friction that's in there and also helps to keep those alveoli open. So if we have decreased levels of surfactant, then our alveoli can collapse and we can have a lot of pain, upon breathing and stuff. Okay. But salt water, if you're in the salt, or if you're in the salt water too long, it's gonna draw fluid into your lungs from the blood. And then if you're in the fresh water, then the fluid's going to actually move into the bloodstream and adjust your blood levels that way, and basically decrease your ability to carry oxygen. Okay? Still going to treat the patient the same way, though. If you have an amputated limb that's on your scene, what's the process of recovering an amputated limb? Well, first off, you have to find it. All right. If finding this amputated limb is going to delay the transport of your patient to a trauma center, then just go. Okay. You don't want to delay transport. You got to get your patient to the hospital. Okay. But if you're able to recover this limb, and take it with you, then there's always the possibility that it might be reattached to have some kind of function, afterwards. The smaller the limbs, the better. It's more digits, with fingers and toes and things like that. Those are easily reattached. But when you're talking about the whole limb, sometimes it just doesn't function as well as it used to. Okay, but that amputated piece, when you find it, you need to keep it cool. You need to keep it dry and cool. Okay, so you can use ice packs. You can wrap it and then submerge it in ice, just as long as it stays dry and cool. Burns. We've talked about burns back in our mod 3. Let's talk about it again. Okay, your first degree, your second degree, and your third degree. Your first degree burns, this is what we call our superficial burns. These are, it involves only the epidermis, right? So this is superficial. So it's the most outer part of the skin. The most common form of a first degree is a sunburn. Your pain, or the patient will be experiencing pain. It's red, it's painful, but there are no blisters. That's your first degree. There are no blisters. Your second degree, which is your partial thickness, the burn itself is a little bit deeper, and so it involves the epidermis and some parts of the dermis. It goes deeper. This also will have pain, intense pain, more intense than your first degree. The skin will be moist, mottled in color, red to white, mottled, and it will have blisters. Your third degree, or your full thickness, this is when the burn extends into, even further into the body. It goes through all the layers of the skin. It involves subcutaneous layers, muscles, things like that. It could go into bone. All right. The area of the third degree burn is going to be dry and leathery. It could be kind of a white, dry, kind of cooked appearance, or it could be a dark brown or charred appearance. The area of that third degree burn will be painless because the heat and the burn has seared through the nerves. And so there's no pain. There's no feeling or sensation of pain at that point. Okay. That's the difference between your first and second and third degree burns. Make sure you know your rule of nines. Okay. Make sure you know the rule of nines. The head, for the adult is 9%. The head for the pediatric is 18. The chest, which is the anterior torso, the chest for the adult is 18, right? The chest for the child, just make sure I'm doing all this right, is also 18. The back, or the posterior torso, is 18 for the adult and 18 for the pediatric. Arms are 9 for both adult and pediatric. The pelvic area, or the genitals, is that 1%. But remember when I said back in your Mod 3 review, I said, just how important that 1% is, even though it's not, a large percentage of the body. If there's any kind of genital burn, they have to go to a burn center. That's a specialty kind of thing. They got to go, right? And then legs for the adult, each leg is 18%. And for the pediatric, each leg is 13.5 up to 14%. So really make sure you know your rule of nines. All the different organs. This is just some A and P stuff, right? All the different organs. Remember, you've got in your right upper quadrant, you have your liver, you've got your gallbladder, you've got part of your pancreas. In the left upper quadrant, you have your stomach, your spleen, and part of your pancreas. In your right lower quadrant, you've got your appendix. And for your females, you have your right ovary. For your left lower, you have your left ovary for your female patients. Keywords, signs and symptoms. So if you notice, this final exam review is going over a lot of signs and symptoms of different medical emergencies. So looking at your medical emergencies, your emergency charts, those yellow, orange, red, green, blue, and purple ones, will be extremely beneficial for you. Okay. Hepatitis. Hepatitis deals with the liver, right? Hepatitis is your inflammation of the liver. Signs and symptoms is going to be loss of appetite, fever, vomiting, fatigue, sore throat, muscular pain, things like that. And then jaundice. Jaundice is where, your patient has that yellowish tinge to their skin. That does occur a little bit later on into the disease process of hepatitis, but it occurs. And your patient will have pain in the right upper quadrant. Okay. Kidney stones. Remember, your kidneys, although we didn't talk about them in the different quadrants because they're not in the abdominal quadrants, your kidneys are located in that retroperitoneal space behind the peritoneum, right? Retroperitoneal, behind, right? So we call those the flanks. So if your patient has flank pain, and you have two of them, right? You have one on the right side, one on the left side. If they have flank pain or pain in that retroperitoneal space behind the abdominal wall lining, pain, sharp pain, restlessness, most likely they might see blood in their urine, but most of the time it's microscopic amounts of blood that we only see with labs. But if that pain starts to radiate around the lateral side of their abdomen and down into their pelvic cavity, then again, that's your kidney stone because it's traveling, right? Your appendicitis, your appendix is located in that right lower quadrant. Okay, signs and symptoms of your appendicitis is that peri-umbilical pain, with that pain localizing to the right lower quadrant. They'll have that rebound tenderness that we talk about, right? Where it doesn't hurt necessarily when you palpate, but when you let go, they'll have that tenderness. Nausea, vomiting, low-grade fever, they just don't feel good. Lack of appetite, kind of guarding their abdomen, things like that. And then gallbladder stones, okay? Those stones, the formation of stones, when those form, they block the bile duct outlet. And remember, the gallbladder releases bile, and it helps with that fat that we consume, that helps to break down the fats that we consume. So if you've got stones and it's blocking the outlet, first off, it's going to cause inflammation in your gallbladder, which is where we get that cholecystitis. But the signs and symptoms are going to be tenderness in the right upper quadrant where the gallbladder is located, heartburn, nausea, vomiting, and they may have increased pain after they eat those fatty foods because that bile is not able to be, released. Okay. Your diabetic emergencies, again, look at your emergency charts. But remember, when you have that diabetic patient, then we've got glucose problems, right? We've got problems with our consumption and usage of glucose. So remember, the normal process is, your patient's going to eat a meal. The normal process, the patient eats a meal, their glucose level will then increase in the blood. Your pancreas secretes insulin into the blood, and that insulin is what takes the glucose from the bloodstream into the cells to be used for energy. Okay. If we skip a meal, and sometimes we do, right? If we skip a meal, you get hungry. And so if we don't have nutrition coming in, then your body's going to take care of itself. And so the pancreas, again, is going to secrete something. It's not insulin this time. It secretes glucagon, and glucagon will stimulate the liver to release its glycogen stores. Okay, glycogen will go through a process to break it down into its most simplest form, which is glucose. So again, our bodies can use the glucose for energy. Now, when you have diabetes, then that means this normal process doesn't occur very well. Okay, your hypoglycemia, let's talk about that one first. Hypoglycemia is a sudden onset. Okay, you're going to have cool and clammy skin, confusion, altered mental status, all the way to being unconscious, right? Hypoglycemia, this is low glucose levels in your blood. And if you don't have the glucose that you need, then your cells don't have it, for energy, and your brain doesn't have the glucose to function normally, which is why we have that sudden onset of confusion. And it happens kind of quickly. You can have patients who take insulin and forget to eat, right? So the insulin is in their blood and it moves all the glucose that they have into their blood, into their cells, leaving none in their bloodstream, right? For usage later. So if you don't eat after you take your insulin, you're going to get hypoglycemic. Your sugar is going to drop. Okay. But hypoglycemia, we can fix that, right? We can fix that with oral glucose if our patient is awake enough to maintain their own airway and swallow. Your hyperglycemic diabetic emergencies, we have hyperglycemia, you've got diabetic ketoacidosis, and HHNS. Those are both diabetic, both hyperglycemic. Hyper meaning there's too much glucose in the bloodstream. Okay. So your diabetic ketoacidosis, this normally occurs mostly with your type 1 diabetics, because your type 1 diabetics are the ones who do not create insulin on their own, so they have to have insulin from an outside source. And what happens with your diabetic ketoacidosis is they don't have insulin. So let's say that they forget to take their insulin or something like that, right? And so if there's no insulin, then the glucose doesn't move from the bloodstream into the cells, okay? And if the cells don't have glucose for energy to break down for that, metabolism for energy, then they're going to use a different source, and they start to break down fat for energy. And when they break down fat, the byproduct of that is ketones. So ketones will be produced when the cells don't have glucose and they turn to fat because they're starving and they need something, right, to create energy. So ketones are produced. And that's where you get this diabetic ketoacidosis. As the ketones are produced in the body, then they start to build up, right? And we have problems. And so your patient is going to they want to get rid of those excess ketones, and they do that by increasing their respiratory rate. And they have that deep, rapid respiratory pattern in those Kussmaul's respirations. So diabetic ketoacidosis, or DKA, is hyperglycemic, where there's not insulin or not enough insulin to get the glucose to move into the cells. So the cells can't use glucose, so they have to break down fat. It creates ketones, and now your patient has excess ketones in their body. They're going through Kussmaul's respirations, trying to get it out. They don't feel very good. They're going to feel like they're sick, and they're going to be warm and dry, and they can go through some of the 3Ps as well if their sugar gets high enough, right? Normally, DKA is going to find the blood glucose levels will be like above 350, okay? But it can still get really, really high, okay? It doesn't have to stop at a certain point, but it can get really, really high. And so you can still have your 3Ps with your DKA as well, okay? Hyperosmolar hyperglycemic non-ketonic syndrome, this is my HHNS. This is also hyperglycemia, right? It says it in the name, but it's non-ketonic, which means I don't produce ketones with this, so you won't have the Kussmaul's respirations with this. The HHNS is normally seen in our type 2 diabetic patients, okay? And our type 2 diabetic patients, their bodies do create insulin. It's just that their cells don't respond as well to it. Okay, and so glucose doesn't move necessarily as easily into their cells as it would for someone who doesn't have this issue. So HHNS, insulin is present, glucose is moving into the cells are utilizing glucose to create energy. All that stuff is good. The problem is that you just have too much glucose in your bloodstream. That's where the problem lies. And so your kidneys recognize this as it's filtering your blood, and it says, oh, I'm seeing things I'm not supposed to be seeing here. We've got way too much glucose, so I'm going to get rid of it. And so it starts to shed the excess glucose, and it does that by, increasing your urinary output. And when you increase your urinary output, it's drawing fluid from your body, so you're losing volume. And again, this is where you're going to see those, you're definitely going to see those 3Ps with your HHNS, because your HHNS is going to have blood sugar readings like above 600 all the way up into the thousands. So this is really, really, really high blood sugar readings, okay? That polydipsia, polyuria, polyphagia. Polyuria is the excessive urination. Polydipsia is the excessive thirst. Because you're urinating so much, then you're thirsty. And then polyphagia is you're hungry as well, okay? And the concern with our HHNS patients is the dehydration and the blood volume loss, or not blood volume, but just the fluid volume loss and all that stuff that can occur and can put you into hypovolemic shock if it occurs too much, right? So you're hyperglycemic. You could get to the point where you have altered mental status, right? Hypoglycemia, you're going to have altered mental status because your brain doesn't have the glucose. And we can fix that with oral glucose. But your hyperglycemia, you have your two different kinds. Diabetic ketoacidosis, which is more for your type 1, where they don't have insulin, and your HHNS, which is more for your type 2, where they do have insulin, it's just not bringing it into the cell as well. And so you have this crazy amount of sugar in your blood. So just remember the patho behind how this works. Your hypoglycemia will be cool and clammy. Your hyper, they're going to be warm and dry. Okay? The different phases of the seizure. The different phases of your seizure. So this is the grand mal seizure that we talk about. Okay? And the different phases of your seizure. Your first one is going to be that loss of consciousness. Okay, and the loss of consciousness occurs because both hemispheres of the brain are involved, and so there's a loss of consciousness during this grand mal seizure. Your second phase is the tonic phase, where the muscles go rigid. It only lasts a couple of seconds before you go into your third phase, which is the clonic phase, where you have that muscular contraction and rhythmic muscular contraction going on. During the clonic phase, your patient could bite their tongue. They may have urinary or bowel incontinence. And then they're going to go hopefully into this fourth phase, which is the postictal phase. The postictal phase is when they're no longer seizing. Okay, so they're no longer having that seizure-like activity. That muscular contraction has stopped, but your patient is unconscious and unresponsive. And during that postictal phase, we hope to see the patient slowly start to regain consciousness. And they go from right at the end of the actual seizure activity up to a complete return to his or her normal level of consciousness. And the postictal phase can be kind of long depending upon the patient, right? Always have your suction ready for airway issues. Always check their blood sugar after they seize, because seizures use up a lot of energy. So we want to make sure that their glucose levels are still okay. But make sure you're good with, what happens and what do we need to do for a seizure. Okay. Can we stop a seizure? No. Do we keep track of the time? Yes. Do we manage their airway as best we can? Yes. So suction and breathe for them in that postictal phase if they need it, right? Until they start to come back to their normal level of consciousness. All right. The operations. I'm going to go through this a little quickly because we just took our operations exam. I'll still talk about it, but I'm going to go through it a little quicker. Okay. So when you're arriving on scene, what do you do with the following issues? So a mass casualty incident. Okay. Remember, mass casualty incident. This is when we have too many patients for the amount of resources that we have available to us. So when you arrive on scene, let's say you were first to get on scene, you have to declare an MCI. You have to declare on the radio to your dispatch that you have an MCI, and you start to request your additional resources. Okay. Estimate the number of patients you have. All of that stuff is, in your scene size up. Get your additional resources coming. How many patients do you have? Do you need specific resources, hazmat, things like that? What do you need? And then start your ICS, your incident command system. Set up your command. Set up your communications, right? You're going to have your triage, treatment, and transport individuals. As more resources get to your scene, you're going to start, having a triage officer, a transport officer, a treatment officer. Set up your different areas. If you're command, you got to set it up and keep control of all of it, right? If someone arrives on your scene with a higher rank as far as leadership and operational experience, and of course they will take over as the IC, and then you will most likely, as EMS, you will most likely fall into the treatment or the transport officer situation. Okay, but when you first arrive on scene, you have to declare that MCI, do your scene size up, get your resources coming, and start setting it up. For your hazmat incident, okay, if you're first on for a hazmat incident, again, scene size up. Don't rush into that scene, okay? Keep people away from it. Call hazmat, right? Request hazmat. Set up the perimeter for your public safety, okay? Look at those Department of Transportation placards, on the tanker trucks if it's a spill or anything like that. Set up your control zones, hot, warm, and cold. And remember, as an EMT, as EMS, we always stay in the cold zone. Okay, so we don't have the protective clothing. We don't have any of that kind of stuff. So we're not going to go over to where the actual incident is. Set up your perimeter, keep people away, and then, wait for your resources to get there so they can go in and they can start deconning and doing all that kind of stuff. We stay in the cold. If it's a major accident on the highway, just like we were talking about in our Mod 5 exam review, when I pulled up the picture of the barriers, right? Who arrives on scene first, they're the block. If you arrive on scene first, you're going to do your scene size up. We always do our scene size up. Estimate the number of patients, request additional resources if you need to, and park according to how many responders may already be there. So if you're first, then you are the block. Remember, you block the scene. You park upstream from the incident area and block the scene. If the fire department is already there and they have already created a block, then you as EMS will park downstream from the incident area, angled away with your back doors, angled away from traffic. Okay. Always wear your safety vests. When you're dealing with a violent patient and you need to restrain them, what are a couple things we need to remember to do? First off, if you restrain a patient, they stay in place. Okay, we're not going to take them off. Okay, it doesn't matter if the person says, "Oh, I'll be good." Nope, they stay in place. The only time that we may remove them is if unfortunately, if our patient deteriorates into cardiac arrest, which would be very bad, and we have to work the patient. But once they're on, they're on. Okay, but there's a way to do this. Okay, when you restrain your combative or violent patients, there's a way to do it. Okay, I want you to, let me pull up some pictures here. You want to restrain your patient on a backboard, supine on a backboard. This makes it a lot easier to move them when you get to the hospital. Because if you tie them to your stretcher and then you get to the hospital, you have to untie them to move them, right? But if you secure them to a backboard, then you just move the backboard from your stretcher over to the hospital bed, right? So always secure them supine on a backboard. The second thing right here, you see one arm down and one arm up. By doing that, that kind of prevents this person to be able to pull their upper body up off the stretcher or up off the backboard and cause additional problems. If you were to tie both hands down at their sides, then they can use their muscles and kind of as a fulcrum to pull themselves up, right? We don't want that. So one arm up, one arm down. Okay, here's another picture. One arm up, one arm down. But I want them on the backboard, not on the stretcher. Okay, never, ever, ever, ever restrain a patient in a prone situation. So these are things, not to do. Never place them prone, because if they're prone, then that means I cannot assess their airway, right? We always have to be able to assess and manage their airway. Never sandwich them between two backboards. Okay, so you're not going to put them supine on a backboard and then strap another one in front of them and sandwich them between the two, because again, one, that's just completely inappropriate, and two, I can't assess their airway, right? It's all about being able to assess your patient and manage your patient. Hang on just a second. Hey lady. I'm sorry. I'm in the middle of finishing up this review. This has been a long review.
Okay.
Hang on just a second. I'm trying to pause this recording. Okay, sorry about that, guys. I was supposed to send an email to my TAs for my class and totally haven't gotten to it yet because this review is going kind of long, but that's okay. So my apologies for that. All right, so let's keep going. So never put them prone, never sandwich them in between two backboards, and then never hog tie them, right? So you don't want to hog tie your patients. You don't want to put their arms and legs and behind their back, right? We never want to do that. We want to still be able to see circulation and all that good stuff, okay? All right, when we're dealing with certain attacks, what type of protection is required? If there's a biological attack, then standard PPE, obviously, but you need to be in a fully encapsulating suit with a respiratory protection, your SCBA, your self-contained breathing apparatus. So as you can see, that's not something that we do normally in EMT and EMS. So you will absolutely have to have your, oh my gosh, your specific personnel for that, right? If you do have some kind of hazmat incident, whether it's biological, chemical, or whatever, remember you want to stage upwind and uphill from the incident, okay? If there's a chemical attack, again, fully encapsulating suits, you definitely want to have everything, everything protected with that self-contained breathing apparatus with that respiratory protection. Radiological attack, okay? So if there's radiological issues and things like that, Specially trained individuals obviously will be getting in there, but they're going to be wearing lead-lined suits. As an EMT, we're going to utilize the three things: time, distance, and shielding. Time, we want to limit our exposure because radiation does have a cumulative effect. So we want to limit our exposure if we're near the the hot zone by any means. We're going to stay in the cold zone, but if by chance you find yourself there, you want to limit it. Distance, stay away from the source, pretty simple. And then shielding, you want to shield yourself or use some kind of concrete building or wall between you and the source, okay? So there's a lot of different protection that you need, and that's why it's so important to have your specially trained individuals to be dealing with all of these, okay? During MCI and triage, RPMs, that's your respirations, perfusion, and mental status. Remember your green, that's your walking wounded. Okay. If you can hear my voice, come to the sound of my voice. Your yellows, that means everything that you've assessed at this point. Respirations, perfusion, and mental status are good. They just can't physically get to you, right? So that's going to be your yellow. Your red is your immediate or your critical. Yellow is delayed. Red is immediate. Those individuals have either something wrong with respirations or perfusion or mental status. It doesn't have to be all three, remember, because we're going to take 30 seconds to triage these individuals. And if we go in and if they're not breathing, we have one opportunity to reposition their airway. If they start breathing spontaneously, we tag them a red. If they don't breathe spontaneously, we tag them a black, and we move on to the next patient. If when we first approach, they are breathing, what's their respiratory rate? If it's over 30, then that's not good. We tag them a red. If it's less than 30, then we move on to perfusion. If their cap refill is less than 2 seconds, then that's good. If it's over 2 seconds or delayed, then it is not good, and we tag them a red. If it's good, we move on to mental status. If they're able to follow simple commands, then that's good. Then that means respirations, perfusion, and mental status are all good, and so we tag them a yellow like we mentioned before. But if their respirations are good, perfusion is good, but they cannot follow commands, then that's a problem. So they're red, okay? And then again, black, that's our expectant or deceased individuals that we talked about just a moment before. So your primary triage happens in the field, takes about 30 seconds. The only thing that we're going to be doing for these individuals is airway management in the very beginning by a simple opening the airway and do they start to breathe or not. We don't bag these patients. We don't give oxygen. We don't do any of that kind of stuff. We don't have time for it, right? And the other thing we can do is we can control bleeding with our tourniquets and things like that. So life-saving bleeding control. Okay. Secondary triage will occur in the treatment area after they get moved from the field into the treatment area, and then the rest of the treatment and transport will happen at that point. But just remember your MCI triage algorithm. That's START, simple triage and rapid transport. Okay. And if you need to see another algorithm, remember, here's your START triage, right? Okay. So all the stuff that we just talked about. So make sure you just, you can pause the video, take a look at this, or, or Google it yourself. But there's your green, your walking wounded. There's your RPMs, respirations, perfusion, and then mental status. Any stops along the way are red. If they've got good respirations, perfusion, and mental status, then they're yellow delayed. Okay. So make sure you're good with that. I think we've got a pretty good review of that, though, since that's something y'all just did with your Mod 5. And then here's your last one, okay? Here's our last page. Emergency extrication. So what are the reasons for the different moves to extricate a patient from the vehicle? An emergency extrication is where there's potential for danger to you or the patient. So we're going to drag or pull the patient to a safe place before we assess and treat. At this point, life is more primary than C-spine. Okay, life is more more important than C-spine precautions, okay? And if you look in your book, this is going to be in chapter 8. If you look at figure 8-14, that's your emergency extrication. Your rapid extrication is when we move a patient from sitting in a vehicle to supine on the backboard in 1 minute or less. We do still consider C-spine, but it's a rapid movement, okay? 1 minute or less, get them out. Get them out of there, okay? But that's the difference between your emergency and your rapid. Different positions that we place our patients in. Remember, Fowler's is when the head of the bed is elevated. You can have semi-Fowler's where the head is only elevated about halfway, about that 45-degree angle, or full Fowler's where they're sitting more upright, okay? You want your patients, any kind of respiratory emergency, they need to be in full Fowler's, right? Because you want them sitting upright as much as possible. Prone position is face down. And remember, we never, ever, ever transport a patient in prone position. You may find them in prone position, but then you're going to have to switch them over to supine. Supine is face up. Okay, your supine position is where they're laying flat on their back, face up, right? If you have a patient on a backboard, they're going to be supine. If you're ventilating your patient, right, assisting ventilations, they're going to be supine, so you can get your good seal and head tilt chin lift and all that stuff on your patient. Recovery position is where they're lying on their side, normally on their left, and it's used to maintain a clear airway in unconscious patients who are not injured and are breathing adequately. So a patient who basically there's no airway complications. I'm not having to bag them or anything like that. They're unconscious. There's no C-spine that I have to worry about. They're a stable medical patient. I can put them in that left lateral or recovery position to help maintain a clear airway in case they vomit and stuff like that. Okay. So that's the end of our review, but don't forget BLS. Okay. I don't know why BLS isn't on here. I'll have to add this on here, but don't forget BLS, right? If your patient is apneic and pulseless, what do? We start compressions, right? If you have an adult patient, it's 30 compressions to 2 ventilations. Doesn't matter if you're a 1-person rescuer team or a 2-person rescuer team, it's 30 to 2. If you have a child or an infant, then if you're by yourself, it's 30 to 2. But if you have help, it's 15 to 2, remember, for those respiratory problems, right? Or the assumption that it's a respiratory problem. So make sure you're good with that. And you remember your BLS stuff, okay? Look at your emergency charts. Those are going to be your best source of information for your signs and symptoms. Look at your emergency charts. I've got all of my previous reviews. Those are posted, but this one was pretty, this one was pretty good. We've been going on this for almost over 3.5 hours now. Okay. Take a look at what you have. Take a deep breath. Think about your primary assessment, right? Life threats always get fixed first. So if it's trauma, look for that bleeding. Medical, look for your airway, breathing, circulation, right? If I give you vitals, what do your vitals tell you? Do they tell you shock? What's the respiratory rate? Is it good? Do I need to ventilate? Okay, I want you to think about that stuff. Okay, so your final exam will be 100 questions. We give you 2 hours to complete it. Remember, your final exam, you have to make an 80 or above on your final exam. You have to have an 80 in the course, 80 as a course average, and an 80 on your final exam to pass. If you make less than an 80, but above a 70, so if you have a 70 up to a 79 point whatever, then we will allow you to retest your final exam. Your final exam is the only one that we allow a retest on. So take a deep breath and get it done. All right. And I will see you guys the next time I see you guys. If you have any questions, please reach out and I will talk to you later.